Assalamualaikum and very good morning. I'm Dr. Said Johari. As a moderator today, welcome you all to our seminar today, which is titled Land Organism, Envenomation and Poisoning. We are here to get a new knowledge regarding one of the very important field in medicine, particularly in emergency medicine, which is envenomation and poisoning caused by land organism. Which is quite common occurrence both in city and rural area. So having a knowledge regarding this field is a must for doctor, particularly the personnel from emergency department. To begin our seminar today, I will ask Prof. Dr. Khaldun to give a bit of intro before we start our seminar today. Please welcome Prof. Khaldun.
Assalamualaikum warahmatullahi wabarakatuh. Very good morning. Welcome again. Welcome back to our third chapter of our EMSS 2022. Well, as per what we have already heard from the previous two webinars, the two chapters, chapter 1 and chapter 2, it just shows that how important these topics being discussed, because there were so many issues that we had came upon with the during the discussion or during the forum at the end of the program. So we hope today our esteemed speakers will start the ball rolling with some important information regarding land organism, envenomation, and poisoning. As we heard from last week's session, there are so many organisms in the sea. So similarly, we have a lot of organisms on land that can actually cause harm to human, and that is involving both venom and also poison. Okay, so these are toxin related issues, and as we know, on land there are plants, there are mushrooms, there are bacteria, there are also all kinds of other animals that is involved with venom production. Okay, so we hope everybody will enjoy our session for this third chapter, and hopefully we can respond to the questions that you put forward during the forum at the end of this program. So with that, thank you, and have a good webinar.
Okay, thank you very much, Prof. Khaldun. So let me introduce our first panelist today, which is Dr. Muhammad Zaki. Dr. Muhammad Zaki Fazil bin Sinik is an emergency physician with a special interest in pre-hospital care and wilderness medicine. He's completed his subspecialty training under Malaysia Ministry of Health in a program in pre-hospital care and disaster medicine in 2019. He worked as a head of pre-hospital care unit in Hospital Sultanah Nur Zahirah, Terengganu, Malaysia. And he also is currently a president of Malaysia's Wilderness Medicine Society and also member of Malaysia Society of Toxinology. So for this, I will invite Dr. Muhammad Zaki to give a talk regarding the challenges in snake-related injury management in Malaysia. Please, Dr. Zaki.
Thank you, Mr. Chairperson, Dr. Said Johari, for the kind introduction. Morning, everybody. Prof. Khaldun. Okay, we're going to talk, having about 30 minutes talk on the most important envenomation that occurs in the land, which is snake bite, snake-related injuries. We've been reported about 5.4 million snake bites occurs around the globe, and is about a majority of the case are from our continent in the Asia, about 1 to 2 million snake bites. All right, and then we understand that most of the envenoming are occurs in most number of the patients that present to us in emergency departments. However, the severity of the envenomation of the snake bite injuries depends on the snake itself and the host factors, which is volume of venom injected and the area of the location site of the bitten area and the size of the victims. And then the last is the effect of our emergency care, which is injuries to the treatment time. All right, there is a lot of research done on about the snake and the venom. However, we have very few research and data on clinical aspect of the envenoming. So we have a problem, challenges in training the healthcare professional in terms of diagnosis, management, and prevention. This is what we're going to talk in about next 30 minutes. Challenge number 1 is to improve knowledge on the epidemiology. In Malaysia, for right now in our emergency department, there is no mandatory data entering for the snake bite. As this is one of the example, a study in the overseas that we are using data that available in our emergency department, in the whole country. So we can get a few data. We can get analysis and new knowledge from the database. So we need to provide the one database on injury, and it can be in-depth injury surveillance on the snake bite. All right, this is a few that available on the snake bite in Malaysia. So it's estimated about 400 per 100,000 population incidents in Malaysia. And then there is most of the patient that present to us came to the emergency department due to the severe envenomation. So we have a few that did not turn up to the emergency department or hospital due to mild or moderate in injury severity. Right, we also have a snake that unvenomous but can cause mortality. This is one of the example in Kemaman, 2017. A patient died due to python. Let's call it python strangulate the body. And then we also have multiple cases due to reticulated python with injuries and disability of the upper and lower limbs, right? However, we do not have collected data in the whole Malaysia. So there is a urgent need for a regional effort, so we can understand the epidemiology of snake-related injury, whether it is harmful to the human and the mild or unaffected injury. And then we also may propose the community-based to understand the real burden, the realistic burden of the disease itself, injury itself. And maybe we can make it a compulsory for emergency department to report a snake bite and put in our database. And we also have a lack of research on physical and psychological impact and quality of life study on the victims of the snake-related injury. And also we need to study on special groups such as the agriculture workers that is most affected with the disease, and also in populations such as children. Challenge number 2 is to increase availability of and accessibility of antivenom. This is recently cases 70 plus having a snake bite in their home area, identified as a king cobra of the Hana, and patient went to the district hospital, and then after 3 hours of bite, patient developed a respiratory failure and respiratory arrest, intubated, and antivenom was given and transferred to the specialist hospital, which is a bit far away from the location. And then patient also having a swelling at the affected area other than the systemic manifestation. And then because of the increasing swelling, patient underwent to fasciotomy. So this is a challenge to our snake bite management in Malaysia. We do not have any antivenom that produced in Malaysia. And then distribution antivenom, most of the antivenom are located in the specialist hospital. Only a few are stocked in the district hospital, which is more rural and more prone to the snake bite injuries. And there is so seldom health clinic that have antivenom stock in their facility. So this is one of the example of the health clinic that been stocked the antivenom, which is Clinic Kesihatan Tekek in Tioman Island. Because of the distance to the hospital is very far, so they've been teaching how to use the antivenom indication and how to manage the complication of antivenom. So by doing this, we can reduce the time lapse between the bite and the provision antivenom. So we can reduce the complications to the patient and unnecessary surgical intervention. Challenge number 3, to ensure adequate clinical use of antivenom. So there is a lack of knowledge on snake ID in our service, in emergency department, also in the hospital. The clinical manifestation, diagnosis, and complication of snake bite, and lack of successful treatment, not only the use of antivenom, but how to manage the adverse reaction. This is one of the example of the patient recently came to the Clinic Kesihatan, and then after that been referred to the hospital, district hospital. All right. Previously, the case snake bite is transferred to the specialist hospital, but with a few of experience of managing snake bite, this patient being referred to the nearest district hospital with the antivenom available, and this patient being managed and monitored in the hospital, developed systemic envenomation, and antivenom was given. This patient was consulted during the bite in the Clinic Kesihatan, also in the district hospital. By doing appropriate and adequate antivenom, we can reduce unnecessary referral to the state hospital. This patient also having adverse reaction in the ward, some allergic reaction, and the doctors that manage patient are confident to treat the patient. So we must put hands in hands, work together with the university, managing, try to put curriculum education on snake bite management in the medicine, pharmacies, and nursing school. So they are exposed to the management of the snake bite in their degree period. So after they finish the degree, they also must have a continuous education program. So the continuous education program must make available in the area which high burden of the snake bite, such as in Cameron Island. I think every year they are doing the extended continuous medical education on snake bite. And then we must share the national guidelines and to ensure all the emergency department have this guideline and follow the guidelines, right? And then snake bite management protocol, a short, very sweet algorithm must be put in the emergency department for them to remember or can refer when they have emergencies related to the snake bite. And others seminar or other activities that related to snake bite also must be promoted. So we go to the challenge number 4, to increase knowledge in clinical manifestation and respond to antivenom. All right, there is a preclinical study. There is a lot of preclinical study on venom, snake, and antivenom cross neutralizing. However, we have a lack of study on clinical study on the snake bite. All right, so we must promote more clinical studies in hospital or in clinic, and about the efficacy of certain antivenom and the safety, complication, adverse reaction of the antivenom. So this is one of the example, a small study in Malaysia about the antivenom complication side effect. So from the study, they found that the majority of the patient, more than 50%, having an adverse reaction, which is anaphylactic reaction after being being administered the antivenom. And by this study, so we know that certain antivenom are more prone to get anaphylaxis reaction, and then we must make sure that administration of antivenom in the secure place equipped with the life-saving and medication to treat the side effect of anaphylaxis, such as the adrenaline, must be made available during the administration of antivenom. So there is a need to do a more nationwide, not from a single center, but we must go to a multiple center and more sample size to understand which antivenom are more prone to get adverse reaction, and we can give a feedback to the company or production company, so they can investigate and make it improve their quality in antivenom production. There is a need to identify in clinical study. We need to a few gaps. We need to study on clinical pattern, such as juvenile versus adult specimen, systemic manifestation of snake species. Certain snake may have a different manifestation, or due to geological location, they may have manifest difference, a bit different systemic manifestation. Therapeutic effect on antivenom used in venom by a different species, such as Naja Kotiao, for antivenom used for Naja sumatrana that we are already used since 2011, I think. But we do not have a solid data on the effectiveness in clinical settings. And then the use of polyspecific antivenom. Most people are prone to use a polyspecific antivenom because it's much easier for them. But however, we do not know the effectiveness and of the polyspecific antivenom compared to the monovalent. There is need to develop partnership between clinician and university research group to identify the gap of knowledge. Challenge number 5, to provide attention and support to the patient suffering from sequelae. This is the most neglected aspect of the snakebite management, which is patient is managed and then lost. And there is no appointment or follow-up for the patient. So we do not understand especially for the patient, we have physical sequelae or disability. So we need to understand their and provide support to them. Some of them, most of them are agriculture workers. They depends on the ability to work. If they do not have time because of the injuries or disability, they may have difficulty to get to earn their money for life. So we must understand this and support them. This is one of the overseas support group in rattlesnakes in America. So they provide a group that can of the patients and also the clinician, so they can discuss about the long-term consequence of the envenoming. So we also have garis panduan kumpulan amanah from the Kementerian Perlindungan Wanita, is for the patient, the victim that affected due to the accidentally snake bite. So they can provide some money to assist them in the treatment, follow up, also during their loss of works, time of work. And lastly, the challenge number 6 is to improve prevention of the snake bite. We have a poor public awareness and also understanding of the public on the first aid management of the snake bite. So there is recently they are still using the traditional method. You put on several herbs and make incisions, sucking, manipulate. This patient is being manipulated, being massaged, be soaked at the wound after the being bitten by a green pit viper, and then this make the depot of the venom in the muscle or subcutaneous being dispersed to the other surrounding structures, make it worse. The toxic effect of the venom to the located bitten area. So we must make it more frequent in what organizing the first aid for the community. This is example of the campaign that done in Myanmar about the prevention and of the snake bite. They targeting the rural population, which most of them are the agriculture workers. How to prevent using the boot, the stick, okay, and clean the house, yeah, and also the use of the torch during night walking. And then we must share the pamphlets with the targeted population which is prone to the snake bite, on what needs to do and what need to not to do, and teach this during the first aid course of snake bite. By avoiding unnecessary intervention which is not effective and also cause more harm to the patient, we try to make them understand this intervention is a waste of time, and promote them to get help, ask for health assistance, and transport patient to the health facility for monitoring and care. So I summarize my presentation for today. snake bite related injury are a serious public health, not only in the world but also in Malaysia itself. By the overcome all these 6 challenges in Malaysia, we can improve the snake bite management in Malaysia. We can do this by coordinating partnership with diverse stakeholders in government, in Ministry of Health, Ministry of Education, and also collaborate with the NGO and community. So the study and proposed solution should be considered in the future for benefit of the victims of snake bite. For that, I thanks.
Okay, thank you very much, Dr. Zaki, for very informative session this morning. So all the questions that have been asked just now will be answered during the Q&A session. Okay, so we move to the second speaker today, which is Dr. John David L. Comandante, which is from Philippines. He's a clinical toxicology consultant from Emergency Department Medicine and Clinical Toxicology from Hospital Eng Makati. So for his basic teaching, this is undergraduate from University of Philippines Manila in Philippine General Hospital. Then he later on continue his specialty training in emergency medicine in Makati. He later on take a fellowship, specialty training in clinical and occupational toxicology and national poison under National Poison Management and Control Center in Philippine General Hospital. He is an esteemed founding member of Philippine Toxinology Society. He's a board of director and head of section of special interest group in Philippine College of Emergency Medicine. He is also a technical working group member for Philippine Snake Bite Initiative and coordinator for Hospital Makati and Pan Asian Resuscitation Outcome Studies, part of Asian Association for EMSS. He also organized and be a resource speaker for multiple toxinology related seminar and conference in Philippines and also all around the world. So it is my honor to invite Dr. John David to give a talk on centipede and venomation.
Good morning, everybody. I'm Dr. J.D. Comandante. I'm from the National Poison Management and Control Center from the UP College of Medicine, Philippine General Hospital, and I'll be sharing our experiences in centipede and venomation. These are the objectives of my lecture. First, I hope I would be able to describe the epidemiology of centipede and venomation in those settings, and the data has been shown from 2013 to 2021. We had actually a total of 54 inpatient referrals. Most of which are referrals from the emergency department and 76 telephone referrals across the country. There were no deaths reported, and majority are having minor effects of envenomation. Majority are adults and commonly occurring indoor. If you would see in the epidemiology of centipede envenomation, there could be a difference between the indoor and outdoor, but in some references, still they would actually prefer they would actually have envenomations occurring indoor because there could be dark and warm spaces during the night. They have actually lack of protective clothing, which put them at risk for centipede bites. As we know, the bites are occurring majority at night and during the rainfall, which would actually coincide with their reproductive seasons. Majority are in the extremities and in their hands. And apparently there's actually equal risk for children and adults, but we can see majority in the data also presented in the demographics and as seen in our cases in the Philippines. And this is actually the table seen in Hong Kong Emergency Department. Majority are still adults, with females more than males, and we could see that majority would coincide during the rainfall seasons, and mostly occurring at night and indoors. So if we see Are centipedes, there's a misnomer for the name centipede, as they don't really have 100 legs, no? This is actually an arthropod belonging to the class Chilopoda, which had elongated and multi-segmented single pair of legs on each body segment and one pair of antenna. There are actually three medically significant orders, no, as highlighted in the box. You have your Scutigoromorpha, your Craterostigmomorpha, your Lithobiomorpha, Scolopendromorpha, and Geophilomorpha, of which majority of the documented cases would belong to the order Scolopendromorpha. Majority of them would be actually ambush predators, but there's actually difference between your Scutigoromorpha, which are actually ambulatory predators, and there had been no cases documented of envenomation for Geophilomorpha. They've shown also that in the genus belonging to the order Scutigoromorpha and Lithobiomorpha, some of the species would have shorter quote-unquote fangs. Later we'll be describing that would actually that won't be able to penetrate our skin. So the risk of envenomation probably in humans is still low, but there had been documented cases. And this would include the more recent, no, in the Philippines, we have actually 44 described species of centipede, including the fatal Scolopendra subspinipes, no? Majority of which of our centipedes are actually endemic in our country. So again, I mentioned that they are nocturnal carnivores. They prefer the dark, damp places, usually underneath the rocks, leaf litters, even underneath your sofa, some of your things, your tables, no? And again, I've mentioned that they are actually ambush predators. As seen here, your centipede can actually take down as big as your mice, no? And it's actually widely distributed in both tropical and warm temperate countries. It could grow as large as 30 centimeters, and they differ in color, no? But majority of them would have a color of blackish, black reddish to brown, no, color, depending on the species. So what would be how would they deliver how would envenomation occur, no? Their delivery, the venom delivery apparatus would be through their venom claws, what we call the forcipules. This is actually a modified first pair of their front legs. And at the base of it, there's actually a venom gland. They noted that in terms of injecting the human, it's actually very minute, no? For example, for you to really kill a mice, you would actually need at least 0.01 venom glands per gram body weight needed, which would actually translate and which would actually explain why most of the envenomations occurring in humans would actually lack lethality based on the extrapolation. So it would, like some sort of estimate, you would have at least 1,000 venom glands for it to be fatal. But if actually fatal, no, as mentioned earlier, no, it would be of lesser body weight. So this is actually very significant in the pediatric population, and you would see actually the mechanisms, no, how the centipede will actually give us pathophysiologic mechanisms, no, of morbidity and mortality. So what would actually comprise the venom? If you can see here, this is actually a very good comparison of the composition, no? There's actually a proportion of your high molecular weight venoms and your low molecular weight venoms, to which, no, your low molecular weight would be the most significant components of your venom. And it would actually vary per species. Let's say we see here that your Scolopendra would actually have more low molecular weight venoms as compared to others, no? What would be the components, no? So this would actually try to explain why we're also giving some interventions for centipede envenomation as per their venom composition. So their venom would actually have serotonin and histamine. They have proteolytic enzymes similar to your snakes that would actually give you cytotoxic and myotoxic components. You have also your pore-forming toxins, and other toxins designed for cytolysis and myolysis. Of course, if you wanted to look into how would you actually approach your centipede envenomation, this would be the important things you wanted to note. No? Of course, number one, you wanted to document the incident. Again, what time of the day, where was it located, what would be the circumstances pointing to the envenomation event, no? How would you describe the habitat where the centipede was found? That would be important in terms of prevention and toxicovigilance. What would be the description of the centipede by color and length? Although in reality, description alone will not be sufficient. No, it's actually better to get photographs with scale, at least to identify what type of centipede would that be, and at least it would actually give us an idea on how lethal the centipede would be. No, as of now, there are actually paucity of researches for centipede envenomation. And I think it's high time for us at least to give emphasis on this, since this is actually a commonly presenting envenomation in our emergency department. Of course, we wanted to see the timeline of symptoms, paying attention to neurotoxic, cardiotoxic, and myotoxic manifestations. Of course, aside from it being mostly cytotoxic, no, which would affect certain organ damage, like pointing to your brain and even your cardiac your heart, no, there could be also manifestations like, remember that it has actually a histamine component, so it could trigger a fatal allergic reaction as fatal as anaphylaxis. So in your history, you wanted to elicit the history of allergies, if they're actually chronic diseases that can actually coincide with the neurotoxic or cardiotoxic manifestations of the disease. And of course, you wanted to know the tetanus immunization status, as this is actually important in our management as well. This is actually a very interesting table of those reported clinical effects of centipede bites. No, we would actually include both local and systemic manifestations. As seen, there could be swelling, minimal bleeding. Of course, pain is always there, erythema or itching. There could be as high as eosinophilic reactions and pruritus. There could be nausea and vomiting, no? Palpitation, syncope, or even coronary ischemia. There could be shortness of breath or wheezing as manifestations of allergic reactions. There could be transient proteinuria and renal failure, even rhabdomyolysis and compartment syndrome for severe myolysis and cytolysis. Sometimes, no, again, there had been some instances that it can actually have as major as neurologic manifestation. So there had been reports of centipede envenomation presenting like ethanol intoxication. So it's like Korsakoff like inebriation. And there could be actually some manifestations of extremity weakness rather. Again, I've mentioned about limited local reaction with pain and swelling. Again, I've mentioned it, which would actually have occasionally necrotic debris with skin desquamation after, which is prominent after 2 days, no, 2 to 3 days. Most reaction in an area are less than 5 by 5 centimeters, although there had been reported as large as 10 by 20 centimeters. No? There could be some reports of lymphangitis and painful local lymphadenopathy in the axilla, or groin, depending where the affected extremity was. So here in the data by the Hong Kong Emergency Department on profiles on centipede envenomation, they've reported pain as the most consistent finding in centipede envenomation, followed by erythema, then swelling. Of course, they could have, although there could be numbness and some systemic symptoms, it occurs less than 1/4 of the cases, no? And majority of them would have lower limb as the affected extremity. So actually, just to share you some of our selected cases that I've personally encountered also in my practice. Now, I've seen a 16-year-old female who accidentally stepped on a centipede at night, presenting with minimal swelling, no necrosis, but the pain was actually out of proportion, which prompted emergency department consult. This is actually somehow similar to your stonefish envenomation, where pain is actually very significant, which would actually prompt them for seek of pre-hospital interventions or first aids. No, fortunately, this case, the patient was able to apply cold compress, which actually lessened the pain to 6/10 at time of the ED consult. I've also seen some patients, some 42-year-old female with no known comorbids presenting with local swelling from centipede envenomation, but it's actually not that large. But on ECG, we noted PVCs in bigeminy. This was actually referred to the cardiology service. We've done some cardiac markers, and what was actually unremarkable was sent home on carvedilon. And on further follow-up, there was actually resolution of the bigeminy after 1 week. I have also seen a 3-year-old male. Again, we note that this is actually a pediatric case to which it could be actually fatal. Bitten by centipede on the right temple area, there was actually enlarged swelling as large by 10/15. But after administration of diphenhydramine and cold compress, there was actually resolution and redness of the swelling. So I've mentioned here that it's actually very significant, and this table from the book, no, I've seen in the clinical toxinology of Asia and the Pacific. There's actually a very good list of some patients who've seen as major as hypotonia, diffuse weakness, vomiting, and pale skin. But this is actually ingested. But you can see if there's actually even actually in more in younger patients rather, no, there could be significant manifestations of centipede envenomation. So the youngest I've seen is actually 2 years old. What shall we do? Of course, in terms of pre-hospital management, this is actually one of the things that our pre-hospital providers, no, our paramedics, our emergency medical technicians would want to look into. Of course, we want to recognize life-threatening conditions such as anaphylaxis and acute coronary syndromes. It's always ABCD. Of course, supportive management is very crucial in this case. You may want to do cardiac monitoring. Of course, local wound care like cleaning of wound, ice packs to alleviate swelling and pain. They might want to consider pain medications and elevation of the arm. And if actually there is actually significant swelling, they might want to consider limb immobilization below or at the level of the heart. And if actually their EMS protocols would actually allow them, they would actually administer fluid resuscitation for hypotension and administration of life-saving drugs. For definitive management, we follow these important principles, similar to toxicology. Stabilization is very much important. Of course, we wanted to see the management of anaphylaxis and acute coronary syndromes and even rhabdomyolysis, which is also included in terms of rhabdomyolysis would be your electrolyte imbalances. No? So would your patient present with hyperkalemia or hypocalcemia, hypophosphatemia? Decontamination, no, is very important, such as wound care, external cleaning. And although this is actually very rare, there could be embedded forcipules following the bite. No? If you cannot actually see and you're suspecting that because of persistent swelling, you can actually opt to do imaging such as other modalities such as ultrasound or MRI if you are actually suspecting it. Consider actually hot water immersion, as they found that allegedly centipede venoms are actually heat labile. So this is actually a form of minimizing the absorption of the venoms. There's no role for enhanced elimination and extracorporeal techniques, but if your patient is uremic and suffering from acute kidney injury, probably from rhabdomyolysis, no, you may want to do extracorporeal techniques. No? Currently, as to my knowledge, I don't know, if at least in the Philippines, we don't have the antidote available, and it's purely supportive in management. So what should we do? Of course, we wanted to observe for progression of swelling, compartment syndrome, if the patient had systemic envenomation or myoglobinuria. In terms of pain control, actually, this is actually analgesics is actually our intervention of choice. So any analgesic would do, as low as paracetamol, and NSAID, opioids, depending on the pain scale. And they found in the randomized control trial that using your actually hot water immersion or even ice packs is actually non-inferior to in terms of optimal pain control. And there had been some reports of local infiltration with lidocaine for pain control. Currently, there's no role for antibiotic prophylaxis except if you have necrosis or secondary bacterial infection in the area and the bite site. You may want to give antihistamine for pruritus, and even actually in the survey done in the Hong Kong Emergency Department, the most common modality is actually the administration of your analgesics as part of your supportive care, followed by your antihistamines and antibiotics. So fortunately, in my experiences, I've been using already either hot or ice packs as part of pain control and in Centipede and Envenomation. So what should we do in terms of disposition of this patient? May want to observe our patients for 68 hours for mild envenomation. Of course, if there's actually systemic envenomation, may want to admit these patients. And just mind you, chest pain may occur at least within 1 to 24 hours after the bite. So that's actually at least a window period for you to observe. In terms of outpatient management, you want to observe for evidence of infection. Again, diba, the desquamation may occur after 2 days. So see if there's actually evidence of infection or necrosis. There could be some delayed swelling or recurrence from the bite because of immune mechanisms, like your immune complex deposition, which may resolve with corticosteroid use. And again, there could be proteinuria, which is actually self-limiting. Majority of the bites are actually have excellent prognosis, and even without administration of pain medications, if they just endure the pain, sometimes it's actually self-limiting. It will actually be lessened through time. So unless there had been complications in this case. Of course, the presence of underlying disease, such as, for example, uncontrolled diabetes or sickle cell anemia, would actually complicate the course and would actually progress the swelling, the infection, secondary bacterial infection. And we note that there were actually deaths documented. For example, this is actually a 7-year-old female Filipino children bitten on the scalp by your Scolopendra subspinatus, which died after 22 hours. So that's fairly significant, because it's a bite in the head. Another, although the two mechanisms would have death, not because of the envenomation alone, although the 7-year-old, we are not so sure if the mechanism is due to the venom alone, but in the documented case, a 20-year-old female Thai and Mauritian army officer who accidentally was bitten, or actually accidentally ingested centipede, which noted swelling and asphyxiation and anaphylaxis. So again, this is actually a recognized complication of this bite. So what should we do? Of course, as much as treatment is needed, we wanted patient education. So for the patient to never touch or handle centipedes. And when you're actually gardening, at least because they wanted damp soils, be cautious in gardening soil, or even picking up rocks. You may want to protect yourselves using PPEs, personal protective equipments, Your work gloves will be helpful to prevent your bites, Cleaning and elimination of habitats of this centipede will be essential. Again, in one of my cases, it's actually occurring in the backyard. Perhaps cleaning their possible habitats and crawl spaces under homes, and these are actually well aerated, or at least you seal the openings, such as your cracks and crevices, your entrance in the doors, glass sliding doors, your window screens. This should be controlled so that the indoor bites should be prevented as well. Of course, if you wanted to control, you may actually, pesticides, your commercial household pesticides would actually be sufficient. I just wanted to highlight na kasi even in use of pyrethroid, you can effectively eliminate these arthropods. And of course, hopefully you don't have another toxic exposures from industrial or agricultural use of insecticides. So that's it, if you have comments and questions, here are my numbers. Here are my email address, and you can see here the largest photograph centipede could be as long as 30 centimeters. Thank you for listening.
Okay, so thank you very much, Dr. John Dewi, for the very wonderful talk regarding centipede bite today. Okay, let's move on to our third topic today, which will given by Dr. Musifah Zayana from Indonesia. So let me introduce our next esteemed speaker from Indonesia. Dr. Musifah, introduce you first. Okay. Dr. Musifah is an emergency physician from Saiful Anwar Hospital Malang. She received a undergraduate education in School of Medicine in Medical Faculty Brawijaya University in 1993. Later underwent specialist training in emergency medicine specialist program at the same university in 2007. She has extensive experience as working as a doctor since 1993 and actively involved in clinical and teaching up to now. She has won award for some submission of research paper at Pedosi event So this research paper titled Effect of Pre-Hospital Management Quality and Duration of Event of Initial Treatment of Head Trauma Patient during Revised Trauma Score. So this study was published in 2007. So let me invite Dr. Musifah to share about animal bite cases in Saiful Anwar General Hospital.
Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Good morning, everyone. Thank you to the moderator, Hari Doctor. Allow me to introduce myself once again. I am Musifah Zayana, as a medical doctor, emergency specialist. You call me Sifa Doctor. I am here to present
You
our
want to please-
report is about profile of animal bite cases, emergency department Saiful Anwar General Hospital Manang in 2012 until 2016, 2021, and 2022. Indonesia is a country with high biodiversity. Regarding species diversity, Indonesia has 7.3% of reptilian, 12% of mammals, and 17 of avian, with 270 species amphibian animal, and 2,827 species invertebrate animal, except freshwater fish. The study will describe the animal attack on people who went to Saiful Anwar General Hospital for medication. Animal venom is a significant cause of illness and mortality. More than 5 million people are bitten by snake generally worldwide, and of those 100,000 experience serious after effect. The result, total case 362, average case variance is 52 cases. The highest number of animal bite cases in the 2016. The trend of animal bite case decreasing. The characteristic subject by the type of animal. We can see the graphic. Snake is the most common of animal bite. Snake in the most common of animal bite. There are the 168 cases following the unknown were 36 cases. Unknown bite of animal is defined as an identification animal bite of when the patient cannot describe the cause of bite, but the patient complain the bite and there is bite part. And the dog 20 per case, 4 case, and cat and scorpion 17 case, etc. The characteristic subjective by trice group based on the level of emergency. The majority case P2 or yellow 66%, followed by green trace of P3 with 33%, and 1% of P1 or red state, 3 case with respiratory failure type 2 because seasonic neurotoxin, and 2 cases with septic shock because of green snake. The most common case where snake bite, snake is carnivore reptile, the can product venom. Animal venom is the most cause of morbidity and mortality. Indonesia has many venom snake species. In Saiful Anwar General Hospital, the most venomous snake are hidden snake, cobra snake, bungarus, and sea snake. It can also be observed there is a decline in 2021 and 2022. The study report in 2022 and 2021 and 22, the case of animal bite decreased when the pandemic COVID-19 went on. It hypothesized the people prefer to stay at home during the pandemic. We have lack of data in 2017 until 2020 because the problem is collecting the result by gender. There are 109 cases for women and 253 for men. Male cases are more frequent than female because male activities mostly outside the house, such as farming, gardening, fishing, and etc. The case by age, the most common vary by 16 until 60 years old. There are 200 people or 71.8%. Less than 80 years old, there are 70 people or case 19.3%. And there are more than 80 years old, the 32 people are 80.8%. The highest case is the adult group because the most active group are productive. The most frequent complaints were pain, sores, and swelling. Edema is visually seen after the rise level, ultrasound, so subcutaneous edema, or cobblestone intestinal, no sign of inflammation. With ultrasound using line probe, the edema is seen until the level of 130 forearm. Conclusion. Number one, ultrasound facilitates clinical examination for snakebite envenomation. Ultrasound show more accurate pathology and skin layer compared with physical examination. Number two, cobblestone is a hallmark sign of subcutaneous edema. So there are cellulitis will be sign of inflammation. Number three, the anatomic side of the snakebite is an important factor affecting the prognosis of the wound. From picture, degree of swelling and sores, vulnus morsum, vulnus lacerum, open wound, etc. Seems snake is the most common breed by 72.4%, following a no 9.7%. From the dog, 6.5%, scorpion 4.6%, etc. The most common case animal bite caused by snake, 17.4%. The most severe case caused by snake bite, 2 cases caused by green viper, and 1 case caused by snake. Okay, thank you for your kind attention. If any question, you can tell the moderator. Akhirul salam, Assalamualaikum warahmatullahi wabarakatuh. Good morning.
Okay, thank you, Dr. Musifa, for a very wonderful speech and sharing regarding the cases in Hospital Saiful Anwar. After this, I just want to invite our last speaker, which is last not but least, our next speaker, Ms. Sazaroni Mat Rashid. She is a pharmacist, which is she hold a Master of Clinical Pharmacy from University Science Malaysia, and started her career as pharmacist at National Poison Center in USM in 2009. She's directly involved in the development of antimicrobial resistant toolkit for WHO to Malaysia, NPC as WHO Collaborating Center for Drug Information. She is also actively involved in health literacy education to children in area related to tobacco control, provide consultation to health professionals on toxinology and toxicology in Malaysia. Her interest in the field has led her to contribute in scientific writings, lead a portfolio of natural toxins at PRN, and actively involved in giving talks regarding poisoning to the public and health professionals in various community outreach and scientific programs. So let me invite Ms. Sazaroni to share regarding arthropod sting in Malaysia. Please, Ms. Sazar.
Okay, Assalamualaikum and very good morning to everyone. Okay, can everybody see and view my screen here? Okay, so let's jump into this topic. So basically, I would like to share with all of you about the arthropod spikes and stings in Malaysia that specifically has been referred to National Poison Center, right? So first of all, we need to understand what is the toxin, venoms, and also poisons. So let's go into toxin first. So toxins are the compounds that are produced by living organisms and are secreted by many microorganisms, invertebrates, plants, and also animals. Whereas venoms are the toxins that are injected into another organism via specialized organs such as fangs, teeth, or stings. So venomous animal is one that possesses a specialized organ to inject or transfer its toxin in the body of another organism as an offensive or defensive mechanism. So poisons is the toxin that are consumed or passively exposed over a period of time. So let's look into venomous arthropods. So basically arthropods belong to the invertebrate phylum Arthropoda and the taxonomy classification. So arthropod is characterized by bilateral symmetry, segmented bodies, jointed paired appendages, and hard exoskeleton. There are venomous arthropods which are responsible for many injuries reported worldwide, such as from the class Arachnida, such as scorpions and spiders, class Insecta and the order Hymenoptera, such as hornet, wasps, and bees, and the class Chilopoda, centipedes, Dipopoda, millipedes, and other orders under class Insecta, such as Coleoptera order, the beetles, Hemiptera, such as stingbugs, giant waterbug and cicada, Hymenoptera, such as fire ant, the Solenopsis, and Lepidoptera, such as butterflies and moth. But these orders are not going to be covered in this slide, however. We are going to look into a few that commonly referred to National Poison Center. So findings from our center, National Poison Center, there are a few cases referred to Malaysia NPC from year 2016 up to 2021 found that 167 cases of all types of poisoning agent were caused by exposure to natural toxins, which also include what we call such as fungal poisonous toxic mushrooms, and also marine animals, envenomations, the arthropod as well. So from this number, around 23% involve venomous arthropods, bites, and sting. So let's jump into the first class of our venomous arthropods here from the Arachnida. Approximately, there are around 1,500 species of scorpion described worldwide are venomous. 75 evidence to be dangerous to humans. The more lethal species from this spectrum are from the family Butidae. They are most in yellow color, brown, but black color also exists. And the effect of the scorpion sting is highly dependent on the species. Some manifest neuromuscular toxic effects, the cardiovascular toxics, nephrotoxic, and so on. But usually the venom is so rich in neurotoxin. Scorpion envenomation in Malaysia. So we are lucky because most scorpion envenomation in Malaysia, in our country, causing sharp pain, swelling, numbness, and paresthesia of the limb. So far, there is no fatal case reported which involve scorpions in this country. And these are a few of the scorpions in Malaysia that well documented. Yeah, there are other species as well, but from the documented and well published are these heroes here. The black scorpion, the Heterometrus longimanus, this is 12 centimeter long scorpion, and its natural habitat is in the jungle and can be found underneath the logs. The wood scorpion, the Homerus australasiae, is the most abundant and the smallest scorpion. It is around 3 centimeters long, black and flattened, and it also shares the same habitat as the black scorpion. And the third one is the spotted house scorpion, the Isometrus maculatus. This one is the most severe. It has the most severe sting, the venom, among all Malaysian scorpions. And when a patient alleged has been stung by the scorpion, it is actually we need to obtain full history about the incident. We need to measure the blood pressure, the respiratory rate, the ECG, and also blood sugar, because most of the time when patient got stung by the scorpion, it can the venom can cause hyperglycemia. And we need to observe, investigate the local reactions such as local swelling, redness, local pain complaint from the patient. And then the systemic reaction, we need to monitor at least for 12 hours. And the treatment for scorpion envenomation is merely symptomatic and supportive treatment, because there is, even though antivenom has been approved, but however, it is not available in this country and also in this region. So from the clinical feature side, when someone got stung by the scorpion, it can manifest a systemic reaction. You can go through all the symptoms as in the slide. It also can manifest the local reaction, the local swelling, pain, the numbness, and erythema. It also may cause immunologic, the hypersensitivity reaction. So this is a summary about the clinical features, the signs and symptoms of the scorpion's envenomation, and also what to do in the first aid measures and also at the emergency side in the hospital. It is important to note that the symptoms produced by this venom is purely species specific, especially for the systemic envenomation. One of the slides previously, I've shown some species that produce cardiovascular toxic effects, so on and so forth. Luckily in Malaysia, the species that we found in our country has none of these toxic effects. For the local reactions such as local pain, paresthesia, numbness, local edema, erythema, all scorpion can cause this kind of symptoms, as well as the immunologic, the hypersensitivity reaction. All scorpion can cause these symptoms. Okay, so however, the symptoms of the severity, the extension of the toxic effects from the venom is more in children as compared to adult. So first aid measures, like our previous speakers has many times remind us about the first aid measures. We need to calm the patient down, and then we need to reassurance the patient, do the wound cleaning and disinfection. As for the assessment and diagnostic, we need to monitor for signs and symptoms of systemic envenomation for at least 12 hours from the time of incident. Some of the symptoms, especially the systemic symptoms, may develop later, so we really need to monitor all those. And as for the management, the symptomatic and supportive treatment is applied. We need to carry on the local pain management, things like that. And the antivenom, yes, it is available in countries like Brazil, India, Israel, Mexico, Saudi Arabia, South Africa, and USA, but not in our region. Okay, the second hero is the spider. Okay, So spider, there are around 30,000 species of spiders worldwide. Around 200 species are medically significant to human. And all spiders have venom and gland and fang. That special organ we call chelicera. This is exception to Uloboridae family spider because their venom gland is reduced. So, but other family of spider, they have this kind of chelicera which has the venom and can inject into other organism. However, they are harmless to human due to several factors such as their fang is too short to penetrate the venom into human skin, and the amount of venom is small, and also because of the toxic features of the venom itself. There are a few genus of spiders which are dangerous to human and can cause fatality, such as the Attract species, the Leptrodactys species, Loxosceles, and Phoneutria species. According to the way, their lifestyle, we can divide the spider into two categories: the sedentary lifestyle, which share habitat with human in our house, okay, the long-legged spider, the Phocus species, the Sella spider, Tegenera species, but these two are harmless to humans. So the common spider we found in our house, they are considered as harmless, okay. Do not panic. All right. Okay, next, we shall also can share the same habitat with human, the dangerous, toxic, venomous spiders such as widow spider, yeah, Leptrodactys species, the brown spider, also the Loxosceles species and Crescentium species. Another type of spider, according to the way they live their life, is wandering spider, the Phoneutria. It is very dangerous to human and may also enter our house while hunting for prey. However, good thing is most of these venomous spider not yet discovered in this country except for Leptrodactys. These are photos of the venomous arthropods, the spiders which can cause toxic effects to human. The black widow spider, the widow spider basically because it has black and brown widow spider. The brown recluse spider, the Loxosceles, which also can cause Loxoscelism. The Phoneutria species, the wandering spider, and the Attract or the funnel web spider. So these are all the medically important to human. Okay. So let's look into widow spider or the Leptrodactys species. We have two types. The brown widow spider, its scientific name Leptrodactys geometricus. This one is more commonly identified in this country and can be found in urban areas as well. The venom of the brown widow spider is as potent as the black, the Leptrodactys mectens. Medical management is recommended for patients who develop the distressing local pain refractory to simple analgesic, and for patients who also have any clinical features of the systemic envenoming. The local effects produced by this venom, basically it can cause radiating pain and lymph node involvement as soon as 5 minutes after the bite. It can evolve over next 30 minutes to several hours. And as for the systemic symptoms, it can develop after an hour and rarely may be delayed for more than 24 hours. This is the case report produced by our doctors, our experts in this field, toxinology. This is published in 2021, the Envenomation by the Leptrodactys geometricus, the brown spider in this country. It happened that the victim were bitten on the ear while putting on the motorcycle helmets. And the species has been identified and confirmed by DNA barcoding. Look at the clinical features, diagnosis, and also the treatment. When a patient claim or alleged has been bitten by the spider, we have to obtain the history of the incident. Again, we need to measure the BP, the respiratory rate, the ECG, as well as the blood sugar. And the observation or investigation at the local reaction and systemic reaction need to be performed. And on top of that, you also need to check whether is there any symptoms such as conjunctivitis, keratitis, and so on. If, let's say, patient involved or exposed to bird-like or tarantula spiders, which the problem here is about the urticating hair that has with the spider. So treatment again is the symptomatic and supportive treatment. Patient with signs of systemic envenomation, a candidate for antivenom. However, it is not available in the country. So this is the summary about the clinical features, the signs, symptoms of spider envenomation, and what to do in the first aid and also at the hospital site. So the Loxosceles species, remember the what do we call? The Loxosceles may cause loxoscelism, where the necrosis, the hematologic reaction may occur following envenomation. Okay, and then other species may produce neurological effects, which involve cholinergic effects, which may cause vomiting, profuse sweating, hypersalivation, increased bronchial secretion, priapism, bradycardia, and arterial hypotension, as well as adrenergic effects also possible. The symptoms such as tachycardia, arrhythmia, arterial hypertension, and hyperglycemia. And also the somatic effects such as muscle fasciculation, spasm, muscle pain, and motor agitation. The species which can cause this kind of symptoms, this spectrum, attract species, the hydronage species, Leptrodactylus, Phonitria, and Arania species. All spiders may cause local pain, swelling, and redness. And the Loxosceles species, which can cause necrosis to the tissue. It takes around 24 to 48 hours for symptoms to develop. And the skin symptoms such as urticaria, papular dermatitis, and to eyes such as conjunctivitis, keratitis, mostly caused by bird spider-like species or the tarantulas. Okay. All right, so we can see the first aid measure. What are the assessment and diagnostic to be performed, like monitoring for signs and symptoms of systemic envenomation, again for at least 12 to 12 hours. Some of the systemic symptoms may appear delay, so we need to prolong our observation period. And the management is again symptomatic and supportive management. We are focusing on local pain management, and the wound dressing and care. Possibly antibiotic may be needed in the case of where necrosis foresee. Hemolytic parameters to check for any clinical lab parameters that relate with the hemolysis, such as hemoglobin, hematocrit, and so on. The antivenom, the aim is to neutralize the venom. This is especially true for patient who has the systemic symptoms. However, the antivenom is not available in this country and the region. Next, we look at the order Hymenoptera. Okay, the Hymenopteran stings are the cause of the majority of death due to venomous animal in the US alone. Okay, death is either due to anaphylactic shock or local swelling subsequent to stings to the throat area, neck, or airways. Within the Hymenoptera order, the 3 families of stinging insects and dangerous to humans are Apidae, such as honeybees and bumblebees. The Vespidae family, such as hornets, yellow jacket, and wasps, and the Formicidae, the fire ants, the Solenopsis species. Okay, the cross-reactivity. There are studies found that the possibility of cross-reactivity between the various Hymenopterans, and the cross-reaction can occur within Vespidae species, within among honeybee and bumblebee venom, the Apidae species, and some Vespula venom allergic patients may also experience the cross-reaction to fire and stings. However, the relationship with other species of ant are not well studied. Okay, let's look into hornet wasp family, the family Vespidae. There are three subfamily and the Vespidae. The Vespinae subfamily, the wasps, yellow jackets, and hornets are the medical importance and need medical attention here. Their venom is usually rich in phospholipases, which can produce effects ranging from local inflammation to severe anaphylactic reaction. And in Malaysia, in this country, there are following species. The species has been recorded in this country: Provespa anomala, and the others like Vespa affinis, and Vespa annalis, Vespa bellicosa, Vespa moxariana, Vespa multimaculata, Vespa tropica. This one is very famous and very popular in the country, the tebuan tanah, and also the Vespa velutina. These are the photos of hornets of Malaysia. Okay, and this is the news clip which occurred last year. This case involved 11-year-old boy dies after being stung by wasps. Yeah? And this is happened in June this year. Another case involving 5-year-old boy dies from hornet stings in our country, in Hospital Nur Zahira. Okay, we've touched hornet, and now we look into the wasps, the family member, the Vespinae family. Wasps are known to be more aggressive than bees and can sting multiple times. The composition of wasp venom is very similar to bee family, and medical assessment or observation is recommended if child patient stung by 5 stungs or more, and adult 20 stung or more. Any of the patients experiencing any symptoms other than pain, pruritus, and mild inflammation, any sting to the mouth, throat, eye, basically the head area or the genitalia, and if the patient shows any signs of anaphylactic reaction, anaphylactic shock. Okay, next, the other family under order Hymenoptera, bees, the family Epidae. Bees in Malaysia include honeybee, the stingless bee, the carpenter bee, bumblebee, and also resin bee. But among this, only bumblebee and honeybee are the only two bees of the Epidae family which are of medical importance. Bee stings usually result in acute onset burning or sharp pain with slight erythema and edema, and the medical assessment and observation is recommended if patients sustain more than 50 bee stings, experiencing any symptoms other than pain, pruritus, and mild inflammation, and the sting happened at the head area such as mouth, throat, eye, face, neck, or genitalia, and shows signs of anaphylactic shock. Okay, so these are the summary for clinical features in terms of signs, symptoms, and the management. So in the case of emergency medical, which involve cutaneous, the extensive local skin reaction, we need to provide the cooling, the immobilization, and elevation of the affected extremities. Antihistamine, if required, can be provided. Delayed skin symptoms, we need to provide steroids if necessary. Oral corticosteroids also can be considered. The urticaria, angioedema, edema, and generalized edema, we can provide IV antihistamines, adrenalines, and steroids. And we need to monitor until the signs and symptoms have improved for at least 1 hour. Okay, in the case of respiratory symptoms where bronchial obstruction and laryngeal edema takes place, the adrenaline inhalations can be provided, as well as the steroids. For the local treatment, local reaction, sting which include the surrounding reaction, swelling, redness. We need to basically clean the area, disinfect with the mild antiseptic, and dressing of the wound at regular intervals. Immobilize the extremity with a splint if it involves certain swelling and things like that. Padding and monitoring to prevent pressure necrosis, and tetanus prophylaxis can be provided if patient is not protected. Okay, next is the subfilium myriapoda. This one will refer to centipedes, the Chilopoda family. All orders of centipede are venomous, and the potential danger of centipedes directly related to their size for their venom is not so much toxic as compared to arthropods. Centipedes of medical significance is from the genus Scolopendra, the Scolopendra subsnips, and also Scolopendra morsitans. The millipedes, Diplopoda, however, they do not have poisonous bites, but they do secrete defensive fluids made up of hydrogen cyanide. So with the contact or prolonged contact with this fluid may actually lead to burning sensation and subsequent blister formation. The forcipules is the specialized organ that can secrete or inject the venom into another living organism if someone exposed to Chilopoda. And the centipedes is aggressive, yeah. So this is the Scolopendra, subsnips, and morsitans. I believe we can find this in our country. All right. So the centipede bites can have a wide range of symptoms, from the localized pain, the erythema, bruising and swelling, up to myotoxic, cardiotoxic, and neurotoxic effects. The systemic effects are far less common according to incidences we receive. The most acutely dangerous systemic effect is anaphylaxis. The initial symptoms usually begin almost immediately and are fairly intense, but lessen over the course of the several hours. Next few hours. Medical attention should be sought if patients are bitten multiple times, are concerned about pain following envenoming, and experiencing any unusual symptoms. So these are the spectrum of symptoms, signs and symptoms of after centipede envenomations. So in the mild cases, it can cause local pain, pruritus, edema, erythema. In the moderately envenom, patient may have nausea, vomiting, dizziness, headache, and anxiety. And in the severe case, or the hypotension, lymphangitis, lymphadenopathy, rhabdomyolysis, acute kidney injury, myocardial ischemia may take place. So the first, the management as first aid, we need to wash the skin or cleaning the area with water in order to remove the secretions. The hot water immersion may be useful. Simple analgesic, the pain management basically, and oral antihistamine may be required. Essential treatment for envenoming is actually the pain control, the pain management, the cleansing the wound, and tetanus prophylaxis can be considered, and routine care for any infections or necrosis. Jewelry, we need to it needs to be removed following bites, centipede bites to the fingers area or hands due to the edema may subsequently affect the patient. There is no specific antidote for centipede venom, and the treatment is mainly symptomatic and supportive. So with that, we should end our sharing session today. So thank you very much. All right.
Okay, thank you, Zaza, for the very enlightening topic that she's presented just now. So next, we'll be taking a short break before we go into the forum Q&A session. There will be a quiz afterwards at the end of our seminar today. So the quiz will be hosted by one of my friends. So I will share the link and also the code for the quiz.
Public awareness is fundamental to the success of snakebite management. Improper and delayed treatment of patients with snake envenomation could lead to severe complications and even death. My team will show you the recommended first aid for snakebite situation by using pressure band-aid immobilization method.
Aduh, sakitnya.
Firstly, we need to reassure and calm the victim who may be anxious. It is crucial to keep the victim calm without any elements of panic. Otherwise, it will increase the blood flow and the heart rate, resulting in the rapid spread of venom. Reduce any physical movements and take rest, remove jewelries and loosen tight-fitting clothing, otherwise it may cause swelling.
Rinse the wound with clean water.
Cover the affected area with gauze or gumji if available. If not, you can use clean cloth. Start applying the pressure bandage from distal to proximal of the wound. Not too tight, but nice wrap and can fit a finger through and check for CRT. Apply arm sling to the affected hand in order to minimize movement. Urgent transport to the appropriate medical facility. Maintain immobilization throughout the patient transport to reduce the spread and absorption of the venom via lymphatic and bloodstream. Immobilize the affected limb by using immobilizer. Do use splint or stick to immobilize the affected area. This is to reduce the movement of the affected area in order to achieve the desired pressure level using the appropriate elasticized bandage to achieve sufficient and sustained pressure on the bitten limb.
These are the indications for snake bite. First, we have Malayan crate, banded crate, and red-headed crate.
For coral snakes such as blue Malayan coral snake, Malayan striped coral snake, spotted coral snake, speckled coral snake. Sea snakes such as spine-bellied sea snake, bead sea snake. Transport time is prolonged more than 1 hour for unknown identity. Contraindication for PBI is for pit vipers and cobras. May cause severe local tissue necrosis with increased intracompartmental pressure.
These are the acts that are prohibited in snake bite.
As you can see, this is a snakebite monitoring chart that we use. It should be performed hourly for the first 12 hours. We need to fill in the patient information and the sign and symptom present. The chart summarizes the commonly observed sign and symptom due to the snake envenomation. Monitor for the general condition of the patient. Tick if the patient have drowsiness, vomiting, or abdominal pain. The sign and symptom may vary according to the different snake bite. In addition, we also need to look at the local effect that occur in the patient, such as dermonecrosis, public discoloration of the skin, or blister. Measure the size if present. Next, we examine for the neurotoxic effect which often shown in elapic bite like cobra, crate, and sea snake. This should be performed at least hourly for the first 12 hours. Firstly, ptosis. Ask the patient to look up and observe the upper eyelid. If ptosis present, upper eyelid outward movement will reduce or absent. Secondly, we observe for the external ophthalmoplegia by asking patient to follow the movement of object from patient's left to the patient's right. The affected eye unable to follow in certain direction because of the weakness of the extraocular eye muscle. Next, dilated pupil. This is a sign of envenomation of cobra, crate, coral, and sea snake. Then, broken neck sign as a result from paralysis of the neck muscle. Dysphagia or swallowing difficulty and speaking difficulty is due to the muscle paralysis. Last neurotoxic effect that needs to be monitored is breathing abnormality with a poor respiratory effort due to the paralysis of the respiratory muscle. Using the serial assessment chart, we also need to document any hematotoxic effect and rhabdomyolysis sign. From the inspection of the wound, we document if there is a bleeding from the bite side. Also noted if patient complaining any other spontaneous bleeding from the nose, skin, gum bleeding, hemoptysis, hematemesis, or hematuria. Next, document rhabdomyolysis sign. Ask the patient of any generalized muscle pain and muscle tenderness on palpation. We need to monitor if any dark urine present. We can see the hematotoxic effect usually in the case of pit viper bite, while rhabdomyolysis in the sea snake bite. For the snake bite chart, we need to document GCS, blood pressure, pulse rate, respiration rate, saturation oxygen, pain score, RPP, and tender limb node. RPP or rate of proximal progression is a parameter to monitor local envenomation. It also determines progression and severity of local tissue injury, for example necrosis, bruise, and swelling. It is obtained by determining a fixed time interval to review the progression every 2 or 3 hours. To get the reading, we measure the distance between two micropod tape border, and the measurement will be documented in centimeter per hour. This is blood test documentation. 20-minute whole blood clotting test will be considered if coagulation profile is not available. White blood count may increase due to envenomation. HB will drop if there is a significant bleeding. Platelet may be decreased in victim of envenoming of vipers. For coagulation profile, PT, APTT, INR should be repeated 6 hourly for suspected pit viper cases. Creatinine kinase shows sign of acute kidney injury or renal failure, myonecrosis, and rhabdomyolysis. When coagulation profile is not available, consider doing 20 minutes whole blood clotting test. It's a quick bedside test for unidentified bite or when a pit viper bite is suspected. First step, you should place 2 ml of freshly sampled venous blood in the container. Leave undisturbed for 20 minutes, then tip the container once. If the blood has not clotted, the patient may have coagulopathy.
Okay, so before we go into the forum session, I just want to share another time the link for the quiz and the game code afterwards. At the end of the webinar, we will conducting this quiz. So there will be a prize for the winner. So the prize is the latest land snakes book from Prof. Khaldun. So we will arrange to send the book to the winner. Okay, so without wasting any more time, so I just want to proceed with the forum Q&A session. So for the first question, I see at the Q&A section, there is a question from our participant, which is Sui Yuk Fong. He's Dr. Fong from USM. He's a mangrove ecologist. So he want to know, is if the snake bite kit is on sale in the market with a good first aid treatment. There's usually a long distance to travel from mangrove area to the main state hospital. So I would like to invite Dr. Zaki, if possible, to answer this question.
Thank you, Dr. Said. Okay, to respond to the question, I think this is regarding the first aid of the snake bite. Mangrove, I think, is a mangrove pit viper. So let's say generally the first aid kit is not the suction kits that sold in the market doesn't show any evidence of benefits to the victims. So the mainstay treatment is still, if patient needs, is anti-venom. So we must transfer the patient immediately to the closest appropriate healthcare facility. If you are in the area that is not the facility is not available, the first thing is we must make sure that the communication between the operation in the field of your operation to the medical facility is intact. With the communication, you can get a help for the victim. Let's say if you have a problem, you have a field operation in the jungle, you must find out where is the heli spot. So if we can access you by the land, so we can access you by air. So you must tell your medical or rescue team where is your coordinate for the heli spot. So we through 999 we can coordinate the response using the helicopter service if the patient really needs emergency care. The other one, if you think the emergency ambulance service is not available, you may consider putting your the medical personnel in your team, which is able to give appropriate first aid and life saving to your members of the team during the operation. So in short, the kit in the market is not proven to give any benefit for your members. Yeah, thank you.
Okay, thank you, Dr. Zaki, for the answer of the questions. So next, I would like to invite Dr. Saza, to answer this question from Marcus Lim Lim. So he asked about how many types of hornet are there in Malaysia.
Okay. So thank you, Dr. Lim. Basically, the slide that I share with you all just now is the species that have been documented in or published in the paper. They are not all, because the study, if I'm not mistaken, is in 2015. So by now, I suppose there are maybe the number will get updated and things like that. So far, I have no clear records how many species are there in the country. I hope this is clear enough for Dr. Lim and also other member. Thank you.
Okay, thank you, Puan Zaza. For the next question. Okay, there is a question from anonymous participant. They say the question is, are there any alternative for snake antivenom, especially for hospital without antivenom stock ready for use? So I invite any speaker to share about if there's any alternative for snake antivenom. So okay, Dr. John David, can you share a bit regarding this?
Yeah, actually, we had some scarcity of antivenom in the last, I think, quarter of 2021, and until now, actually, we do have actually limited stocks for our purified Cobra antivenom. We had several experiences of, since most of our snakes are actually neurotoxic in nature, the most medically important snakes are the neurotoxic ones. We had some experiences on the use of neostigmine as an adjunct in treating the neurotoxic signs of snake bite. So that's actually what we have been doing in the last quarter. No?
Yeah, if there's any other speaker want to add on regarding this question. No, I will move to next questions. So the next question will be from Chin YK, one of the participants. He asked, I noticed that most of the animal bite include centipede bees and wasp management mentioned tetanus prophylaxis. May I know it is all cases we need to give ATT or any criteria for determine the cases needed ATT injection? Thank you. So
Okay.
I think Pasazah can answer. Yeah.
Thank you. So again, thank you to Dr. Chin. So basically from what I go through some of the literatures and the references, so basically the clinical features of tetanus, the toxin caused by the Clostridium tetani that's commonly found in the ground. So basically the relationship between tetanus and also the wound or the injuries is well known for for many years. Yeah. So basically in the case of where patient is immunodeficiency, having wound or cut prior to envenomation, for example, or maybe diabetic, uncontrolled diabetic patients. Okay, so this kind of cases require, we need to provide the ATT, tetanus prophylaxis. Also, we need to look at the vaccination history for how many doses, whether it's complete, and we look at the cleaning, the sting or bite area, whether it is clean or not, or things like that. So basically, it's not that so far I didn't come across any solid recommendation. What are the nice criteria for patients that require prophylaxis of tetanus or not. But I believe in this session, we have lots of experts and doctors as well. Maybe you guys can share some of your experience and how do you practice this in your hospital setting. From my side, I think that's all. Yeah, we can always look at the WHO websites regarding the tetanus prophylaxis. Yeah, thank you.
Well, as you know, tetanus, the source is Clostridium tetani. So the toxins that it produces because of the exotoxins, and that can cause neurological problems, right? So when do we give prophylaxis? Well, it's not prophylaxis. When can we give a toxin booster, tetanus booster? And this booster is from ATT. So as you know, if someone is bitten by an animal, any animal that breaks skin, that's a kind of a source for the infection. So we have a general rule of how to give ATT if somebody is already protected, meaning completed the whole cycle of tetanus immunization. And you know, in Malaysia, we have a program for that, even for mothers who are giving birth. So we have a tetanus program. So if you are already protected, there's no reason why you need to give ATT. And that said, depending on how long after you got your protection. So if it is less than 5 years, there's no need for you to give ATT to the patient. If it is more than 5 years, yes. Okay, so that's why you have to ask when was your last ATT booster? Sometimes people fell down from motorbike accident. They got already yesterday, and they got already ATT. Today they got snake bite. They give also ATT today. So that is not appropriate. So you have to always ask, when was your last? Some patient will remember when they got their injection from, and that's why when we inject patient, whatever we give patient, we have to inform patient what they get, so that they know that they are already protected from tetanus for the next 5 to 10 years. Okay. So it's not just simply giving ATT because somebody got break in the skin. No, you have to know when they were actually given the last dose. Okay.
Okay, so we go to the next questions. This one from another one anonymous attendee. So this question directed to Dr. Zaki. He asked any comments regarding illegal smuggling of unique snake from other countries causing envenomation due to improper handling. He asked, is it rare or becoming more common in Malaysia currently? Zaki can answer.
Thank you, Dr. Shaq.
Okay.
So smuggling is immoral lah, yeah. So you know already it's a illegal things to do. So the smuggling is a illegal thing. So is double problem if you smuggle the harmful snake, the snake, the venomous snake, because usually we do not keep any anti-venom for the species that are not indigenous in Malaysia. So basically, if they want to import the venomous snake from the overseas, they must import with the anti-venom, such as in the zoo. So if it's done by a personnel that illegally bringing the exotic snake, which is harmful, it can cause a problem, not to himself, but may cause problem to the ecology and also to other neighbors or something, friends. So this is become a more popular more popular hobby to keep the dangerous, the most dangerous snake. This is means the person is more popular in the society. So I don't think this is a good trend. So we must make a legal or involved with the government to stop this habit of the dangerous hobby to become more and more popular in Malaysia. All right, so they must stop this madness lah. So the snake is wild, so they should be stay in the wild, not in the cage of the urban area. Thank you. I hope I answered the question.
Okay, thank you, Dr. Zaki. So, there's any other speaker want to add on this topic, in this issue? Okay, if not, I just move to the next questions. So this question asked by Sahuri Teguh Kurniawan. So he asked about the golden period of snake bite. He asked how many minutes.
I give my brief opinion on this. So the golden hours is basically been applied to the trauma. All right. So but it's not specifically means 1 hour of treatment. But it depends on the injury severity, and if you say, let's say this is a snake, so you must identify what is the species, snake species. If we compare one patient to patient and a species to species, some may not need antivenom, but just a monitoring. But some people may need urgently antivenom. So there is no fixed rule for 1 hour. But it can be less than 1 hour. It can be more, about 6 to 12 hours, which whereas the species with just like green peat a wiper, they may manifest, systemic manifestation is more than 24 hours. The patient looks well in the first 24 hours, but patient may have a deranged coagulation after the 24 hours. So that is not, it's not a fixed rule for 1 hour. It depends patient and the species, type of injuries, location of the injuries. That's all. I would like to invite others for their opinion.
Hi, hello. In our experiences in the Philippines, some of our cobras are actually, the venoms are actually potent in terms of comparison with other ASEAN countries. I think we're next to Naja Atra in terms of lethality. We have seen as early as 15 minutes, which is documented in some of our literature. So it would really depend on the amount of venom injected. Of course, for neurotoxic snake bites, we always tell our healthcare providers that the best time to really, the golden hour, quote unquote, for these patients is to bring them as soon as possible with access to the antivenom. Of course, the delays to which would actually give them around access block to the administration of your antivenom would actually cause significant mortality and morbidity in some cases. So we've also seen some patients without neuromuscular paralysis even presenting 4 hours, 6 hours, but they had already signs of systemic envenomation like weakness and ptosis.
Okay, so we will ask for next questions from another anonymous participant. This question is for Dr. John David. He say, would you know if research for infectious and tropical medicine in south of Manila still producing antivenom? So, Dr. John David.
Yes, actually, we're I think in some of our lectures in the Rex ASEAN, we've listed as one of the countries that still produces our own antivenom. There had been a recent introduction of a commercially available antivenom that is actually polyvalent, that has actions for Ophiophagus hana, Naja samarensis, and Naja philippinensis. But I have yet to see those data, the clinical and the preclinical studies on this. Although they have been marketed already for compassionate use only, we're still producing, but on a smaller scale. As published in the RITM website, we've been producing like 6,000 vials. But I think it's not enough based on our ASEAN situation antivenom market study. That has been reduced to at least 4,000 in a year. So, and in one patient, we've been using at least a minimum of 5 to 10 vials, depending on the degree of severity of envenomation. So you can just imagine how many patients would just receive 4,000 vials of antivenom. We're still in the process of improving our antivenom production. Hopefully, we can actually shift to the more reliable methods for developing, hopefully genomic methods for producing your antivenom. So we're still using the horse method for producing our antivenom.
Okay, thank you, Dr. John David. So I will move to another question. This question is for Ms. Azhar, asking regarding the management for allergic reaction and anaphylaxis with respiratory symptom. He asked, can clarify regarding net adrenaline again?
Okay, so thank you, Dr. Anonymous. All right. So basically, in terms of anaphylaxis or the which involve respiratory symptoms, so basically is we in Malaysia, we still need to provide symptomatic and supportive treatment. depends on the symptoms that manifest by the patient. Even though in the reference that I share with you guys mentioned about the adrenaline, it is the first treatments in terms of IgE mediated reactions. But if we don't have, I mean, it's not available or for other reasons as well, we still need continue to manage the patient symptomatic and supportively. Yeah, for salbutamol to treat bronchospasm, it's okay. We can continue with the symptomatic and supportive treatment. For your information, the references that I refer for this sharing session is from the New Zealand Poison Center database, which we commonly use in the case of poisoning and envenomation, and also from the vapaguide.info. Yeah, I think that's all from me. Maybe our experts, Dr. Khaldun, or maybe other doctors, colleagues here would like to give comments. Please do so. Yeah, thank you.
Yeah, I think I've never used actually nebulization of epinephrine for anaphylaxis, since I think it's fairly accessible to inject your epinephrine intramuscularly. And I think there had been some head-on comparisons of intramuscular and intravenous route for effect, no? And then the certain location, if it's deltoid or vastus lateralis, in terms of absorption of epinephrine, and I think it's non-inferior. It's the vastus lateralis is superior over your deltoid muscles. That could be, I think, a good adjunct if you use your nebulization of your atropine, especially if you're still having increased swelling in your larynx. Of course, the emergency stabilization like intubation is still the best way to do, because you wanted to prevent respiratory collapse from airway obstruction.
Okay, so we'll go to the next questions, which is this participant asking, does drinking snake blood, snake bile, or eating snake can be an aphrodisiac, which is commonly practiced in most Southeast Asian countries? Can this taboo practice cause snake envenomation? So I would like to ask any of the speaker to give.
Okay. About the drinking blood, snake blood, is it drinking snake blood? In I think in East Asia, they drink a wine with a snake inside the inside the wine. So I think it just almost similar, because of the maybe they claim there is a potential benefit. However, the harmful effect of the venom must be injected to the body, so it's not give any effect if you swallow, because it's a amino acid, a protein. So basically that generally it doesn't cause any harm, but it's not a good practice lah, yeah, to drink snake blood. I think for some of the benefit, all right, or a liver. The venom is a product produced in the venom gland, not in the blood or in the liver of the snake. So if you drink a blood, just get a snake blood for your nutrient. That's all. Yeah, thank you.
Thank you, Dr. Zaki. So next question, there's a question from Dr. Angga. This question is for Dr. Musifah. He asking how many snake bite cases are there in Indonesia and what should be done if in Indonesia?
Okay, there is in Saiful Anwar Malang is data 262. 282. There is data in Indonesia, but in Saiful Anwar 200 activity. Thank you.
Okay. Is it that's all, Dr. Musifah? That's all?
Yes. Yes.
Yes, okay. So I move to the next question. It's quite interesting. Say, in identified venomous snake bite, is there any benefit to give prophylactic antivenom if there is no sign of envenomation? So I would like Dr. John Dewi, you can share a bit.
Yeah, that's a very interesting question because it has been practiced as well here in the Philippines, and sometimes it just any random snake they think that our purified cobra antivenom will actually work. So that is actually one of our initiatives when we started a branch of remote envenomation consultancy services here in the Philippines to Dr. Khaldun. We've been trying to educate these people. Of course, there's no role for prophylactic antivenom administration in these cases, and we have already a scarcity of antivenom, and why give it to someone who's not even presenting with signs of envenomation? And the worst thing is that they administer the wrong antivenom to those snakes that has been quote unquote envenom, but only to find out that there's actually only no signs of envenomation or even just local signs of envenomation, mild swelling, without neurologic signs, or they could be presenting with hematologic manifestations.
Okay, thank you, Dr. John. So next question is from Tan Chun Chow, asking for Dr. Zaki. He asked, can I know any role of antivenom for snake bite during CPR, and any role of subcutaneous adrenaline for previous known anaphylaxis patient before antivenom?
All right, I think thank you for the question. I think in patient develop cardiac arrest, that's why they are doing CPR. All right, so for the cardiac arrest, the mainstay is still treat the causes of cardiac arrest lah. Yeah, for example, if you think it's due to ophiophagus hana, muscle paralysis, and patient hypoxic, respiratory arrest, and develop cardiac arrest, maybe you can adjust a bit, give a priority for breathing during your CPR. So you must start blow, respiratory ventilation support, oxygenation priority compared to the normal CPR, which is you more emphasize on cardiac massage, external compression. Okay. So if you think a patient develop this manifestation, respiratory failure, so you must reverse the etiology of the cardiac arrest, which is due to respiratory problem, and others are almost similar. If you want to give the antivenom, okay. If patient survive, develop organized rhythm, resume of spontaneous circulation, and then you think you want to revert the effect of the venom, and then you can give antivenom after that, not during the CPR. All right, complete your CPR, patient survive, and if you think it is ophiophagus hana, and then you administer monovalent antivenom to the patient. And then the other thing is anaphylactic. Second is the prophylaxis antivenom for patient with the history of
any role of subcutaneous adrenaline for previously known to have anaphylaxis, patient that previously known to have anaphylaxis before antivenom.
All right, if the patient already, we know patient having anaphylaxis due to antivenom, we must make sure what type of antivenom they are allergic to. If different antivenom, you may consider a steroid and also antihistamine before the administration of the antivenom. However, if you don't have any choice, patient having a problem with similar snake species before, and then have a similar anaphylaxis reaction, you have to stand by, put everything on standby. When you start the antivenom, patient may have a secondary collapse, and the antivenom is already available to the patient. Sorry, adrenaline is already available to the patient. In short, you may consider the intravenous also, slow bolus. What we need in short is a good setup with the responder which is trained in life saving, and the equipment and medication to support the patient.
Okay, thank you, Dr. Zaki, for sharing. I noted there is not much of a question remaining in the Q&A section. So I open to any of the participants to ask questions to the panelists. If any of the participants want to ask question, they can just ask. Open up the mic and just ask the question.
Okay. I want to add the question. During CPR, we do not give antivenom, but we perform HRS first. And subcutan adrenaline for prophylactic and anaphylactic action is no needed. Thank you.
Sorry, this question is what? Do we give antivenom during CPR?
Yes.
Is it?
Yes.
Yes.
Yeah, I've responded to that. But the thing is that if a patient is known to be a snake bite victim and you don't know what is the snake that bit the patient present with acute neuro symptoms, especially collapse, and they can't provide any history, but you know that the patient has a sign of a snake bite. But before that, patient already collapsed, so you should start CPR anyway, right? But during CPR, maybe you get the information that patient was bitten by a snake, and most likely the snake that can cause a very acute what you call neurovascular collapse like this, or cardiovascular collapse, is from neurotoxic snake bite. So what's the choice of antivenom? Are you going to wait until patient have a what you call ROSC before you give antivenom or not? So the answer is no. You give, if you have already confirmed patient is bitten by a snake, or most likely bitten by a snake with acute cardiorespiratory arrest, you can give antivenom while doing CPR. So we've done that as well already in Malaysia. So we had a child collapse on the way to hospital, arrived with asystole, no breathing. So we start CPR and we have already identified the area that is bitten. So we straight away continue CPR as usual, but we also add on the snake antivenom. We give at that time she was consulted to REX, so we can straight away recommend Cobra antivenom for the child, which we give. And during CPR, after the completion of the antivenom, the child opened the eyes. So you know, it's a kind of a very miracle thing to see. But that's how neurotoxicity on from snake bite can be very quickly reversed with the appropriate antivenom. Very unlikely. So let's say you don't know what beat the patient, then you can have a choice of what we call neuropoly neuropolyvalent or polyspecific neuro antivenom. So that's the choice that you can give. But for this child, the experience that we had, the child was bitten on the hand, and very telltale sign of a cobra bite. Okay, Naja species. We don't know which Naja species, but there's a dermonecrosis. So we straight away give Naja cautia antivenom for the child, and it reversed the neuroparalysis. And the child survived, and the child, went home, but with some area of what we call scarring from the dermonecrosis. So, but she lives. Unusual if somebody is bitten by a pit viper to collapse. So that's kind of out of the question in terms of which should we give a hematopoly antivenom for the patient. The answer is no. So the one that caused cardiorespiratory collapse is because of respiratory paralysis, and that kind of knock-on effect onto the heart, causing asystole. So hypoxia causing asystole. Okay, so that's what happened to the child. We start CPR, open airway, provide sufficient blood circulation and also oxygenation, and on top of that, we reverse the paralysis. So the child may have already recovered from the get the ROIC before the paralysis is reversed, but she can't open the eyes and move, right? But in our situation, this happened where we also remove the neuroparalysis, and the child straight away opened the eyes and able to breathe. The child was sent to PITS ICU, but it was without any problems of prolonged ventilation and so on. So the child was extubated less than 24 hours after the patient was admitted to the ICU, PITS ICU. Okay, so yeah, so that's the first question. The second question is, what was it just now? What was the question just now, Dr. Musifa? The second question? No question.
Thank you for sharing your experience.
Okay, all right.
Okay, so I think we share another question from Shalini Seka. So she asked about in hospital setting whereby the patient is stable, how long do you need to monitor the patient? It is safe to allow discharge, or do all patients require admission? Okay, I invite Dr. Zaki to answer.
Sorry, can you repeat the question? Sorry.
Okay, she asked in hospital setting whereby the patient is stable. So how long do we need to monitor the patient? Then she asked, is it safe to discharge, or do all patients require admission?
All right, basically, we should differentiate between is identified snake bite or unidentified snake bite. So if we identify is a non-venomous and patient is okay with a short observation in your observation unit about 6 hours, you can discharge the patient. If you identify is a venomous, and then you need to keep patient. Usually we keep patient inpatient for overnight observation. But if we doesn't know the species of the bite, unidentified snake bite, we need to at least monitor more than 24 hours. Usually we monitor more than 24 hours, especially if patient having a problem with species like Trimesurus fucata. So we need more than 48 hours. Usually we monitor patient inpatient for more than 48 hours. So basically, if you identify is a non-venomous and patient looks well, such as Lycodon species, wolf snake, or water snake or water puff snake, Molossus buccata, which is common in our community, or so we can just treat the wound, clean the wound, and short observation. Is patient okay? If need analgesia, we just give a PCM, and patient can be followed up in the local clinic.
Okay, thank you, Dr. Saki. There is no other question, I think. For the feedback, form will be provided at the end of the seminar after this. So any other questions? If got any other question, we just, okay, there's one question for Dr. John Dewi. She asked, the person asked is antivenom still made from milking venom from a specific species? If so, how does this work if the target species is protected by conservation efforts? Dr. John.
I think this is a difficult question because I'm not technically involved with the anti-venom production. But I think in theoretical sense, here in RITM, we've been using the old traditional method. But the process actually of creating antivenoms here in the Philippines is that there's actually a certain serpentarium that actually produces the venom that they will be using for processing or hyperimmunizing the horses located in a specific area. So I think we've also raised that questions with our ITM, whether is it really a representative of the true picture of the venom, because as you can know, we are actually asking ourselves, would there be a difference if we got the venoms from the wild itself? And that's actually what have been the initiatives of the Philippine Toxinology Society has been pushing for for RITM versus those snakes that had been caged for quite some time and feeding on a specific diet. We still don't know the answer, but perhaps the counterparts from the Thai Red Cross has actually extensive experiences in this.
Okay, thank you, Dr. John.
I think I would like to add a little more to the arthropods, bites and stings, because if a patient come to the hospital, has been stung or bitten by these venomous arthropods, we need to remember that not all the cases will cause envenomation, because there are cases where the venomous arthropods just provide the dry sting, meaning it's just causing pain but no systemic reaction. Maybe I can respond to Dr. Shalini questions regarding how long we need to observe. Okay, in the case of arthropods, envenomation, whether bites or stings, I think if it involves spider, we can continue observe up to 48 hours, because some of the systemic reactions, especially in the case of the species is unidentified, we need to observe for systemic reaction, because some of them will arise quite delayed. Okay, for example, the hemodynamic, the hematologic reactions, maybe 1 to 3 days like that. So 48 hours is acceptable. But if patients come with the only local pain, single stings, for example, maybe we can, if according to New Zealand Poison Center database, it is recommended to observe for 6 hours and can allow discharge. But in our country, in our community, 24 hours observation is will do good. Yeah, that is what I want to add regarding the questions posted. Thank you.
Okay, thank you, Puan Saza. Okay, Dr. Mushiba.
I would like to add in Saiful Anwar Hospital, we observe the symptom present if there is no sign of local and systemic intervention, we can discharge the patient in our N6 hour. But if there is symptom of local intervention, we observe for 24 hours. Thank you.
So they say, by any chance, they say, is there is a networking between countries in sharing antivenom? So they say, I know antivenom are specific to per species. So they say if there is any like networking between countries to share the antivenom.
Maybe Dr. JD or Dr. Patrick can respond.
Actually, that's a very good question for us as well, because I think the ASEAN countries has been already sharing their antivenom from Thai Red Cross. In the Philippines, we're still, I think we already suggested procuring such, because there had been established antivenoms for shared species, like for example, Naja sumatrana is also shared in the Philippines, and of course the king cobra of Pelopagosana, which we lack specific antivenom, is also available in the polyvalent. Maybe in the near future, we're actually envisioning, as what mentioned by Dr. Calgun, that we could have like a single polyvalent antivenom for the ASEAN region. Right now, we've actually trying to, the thing about the Philippines is that we are actually part of the WIPRO, not technically the CRO region. And there's actually already sharing of antidotes under the WHO to the CRO region. I think it's ICAPS with Thailand. We wanted to actually hitch on that project, but we're still on the initiatives done by the Philippine Snakebite Initiatives. We've been suggesting that, but until now we are waiting still for some responses from them.
Okay, thank you, Dr. Javid. So we are ending the Q&A session. So if any of the panelists want to add on want to answer any question, if no, then I will proceed to quiz. There will be quiz after this. So this quiz will be, there is a prize for the winner, a special prize from Prof. Khaldun himself. So if anybody that win the quiz, please inform your email number in the Q&A section, so we will get contact with you after this.
So I'll end the quiz in 1 second. 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Okay, right. So let's see who's the winner. Okay, so the number one would be Buan Tongge. Okay, so Mr. or Mrs. Buan Tongge, you guys can claim your prize by providing your email in the chat, in the question and answer session. I'm so sorry for the technicalities. Hope you guys enjoy and benefit from the session. Okay, thank you.
Okay, it's quite a very interactive session of the quiz. So for the winners, the winner just now, is Mr. Tebuan Tongge, can leave email in the Q&A session or in the chat, so we can contact you and send the prize to you. For the closing section, I would like to invite Dr. Patrick from Philippines to give a bit of closing speech to our webinar today.
Okay, thank you very much, Doctor. I would like, on behalf of the organizers of this emergency medicine seminar series, together with the co-sponsors and collaborators from the Philippines, Malaysia, and Indonesia, We are thankful for all the participants and our distinguished speakers for sharing their time and their knowledge regarding this land envenomation and poisoning. We hope to see you next time, September 22nd, if I'm not wrong, for another, the fourth of the series of the EMSS 2022. Hopefully we can see you there. Goodbye.
Okay, thank you very much, Dr. Patrick, for very wonderful closing speech today. So generally, I just want to wish thank you for everybody, every participant, and also the panelists that shared a lot of knowledge. Hope we learn something new today that we can use in our practice later on. Okay, so I will share the feedback form. So after you done the feedback form, there will be e-certificate will be delivered to your email.